And thanks so much. Thanks for all the dignitaries for being here, the people from IMéRA, from Fulbright, coming down from Paris to be here, the IMéRA folks. And I just have to say that the IMéRA staff have been just terrific in helping assimilate my boy into school, who's 16 years old, and providing housing and making it easy to get a bank account and all these kind of, some that would have been very challenging, I think, for me alone. But the staff have been just fabulous in getting that done. Certainly to Bruno for being here and working with me for several years and actually making this entire thing really possible. And to Aix-Marseille University for hosting me, as well as the Fulbright, as well as Dartmouth, as well as IMéRA. I do want to just thank everyone for being here, and thank my fellow IMéRA fellows for being here as well. Several of them are here, and even some of the students that I'm teaching in this class that Bruno was just describing made it for this. So hopefully you'll enjoy this. The students might recognize some of this material already because they got some of it already, and we'll move along because we got a little bit of a late start, but we'll need to go a little bit later than what is originally planned, but we'll move along. So I want to just talk about what is geographic variation in healthcare delivery. And it's an effort to compare patterns and costs of healthcare delivered in different geographic regions. And what you try to do is you try to determine how much the rates of utilization or the costs of care vary in different geographic settings, and then secondarily, how much of that variation is warranted, right? Because some of it might make sense. If people are sicker, you expect costs and utilization to be higher. If they have greater needs, you expect them those to be higher. But if they don't, then you would wonder what's the effectiveness of that additional cost and utilization and whether it's actually warranted. So I'm going to describe the U.S. We've had a long history, about a 40-year history of looking at health services delivery variation in the U.S. This is Jack Winberg, who started this field, really, geographic variation in the U.S. in 1973, right, a while back. And just to give a little context, in the same issue where he published his first paper, which I noted to the students is in Science. It's a fabulous journal, right? This paper had been rejected at about 10 or 11 other journals before it got to Science, and it was because it was so kind of fundamentally different. It was kind of a revolutionary paper, and kind of the status quo was from JAMA and New England Journal and places like that this doesn't make any sense. Why would we look at this? But he persisted. It's always a good thing to persist in your educational pursuits, right? And landed in Science in the same issue where Watergate and discussion of the Watergate tapes were being discussed, right? So that gives a kind of, that's how long it has been since Nixon was alive and in big trouble was the last time, was when this first started. And what Jack Winberg did, he lived in Vermont, he was an epidemiologist in Vermont, and he divided Vermont, a very small state, about 300,000 people in the US, into 15 different health services areas that were defined by the hospitals that people used. And he just looked at care, at the cost of care and utilization of care in these different areas in this very small state in Vermont. And what he found was substantial, huge variation. You would think it's a homogeneous population, and he found twofold variation in hospital use differences, in the supply of services, supply of beds, the supply of physicians, and the expenses in this little teeny state, 2- to 3-fold differences. And when he looked at specific surgical procedures, for instance, he found huge differences. Tonsillectomy rates varied by 12-fold across the state, according to these per capita rates of utilization in these 15 different areas. And he actually lived in Vermont, as I said, and he lived on right on the border of two of these areas. And he said that in his book, he says that had he lived 100 yards, 100 meters to the north, 3 out of 4 of his kids would have gotten tonsillectomy because that's just how they practice there. But where he lived, only 1 out of 4 of his kids actually got tonsillectomy because that's how they practice there. So he was just kind of stunned that just because of where you live determines so much of what health care you actually get. And his real innovation, and this is probably why it didn't get published in New England Journal or JAMA, was to say, hey, that there's a lot of uncertainty about the effectiveness of care. That's what this raises, that there's lack of clarity about what actually works and what people should be doing. And he raised a second really important point, that just as there might be too little care in some areas, too much care actually might cause harm too. If you're getting too much stuff that's unwarranted, exposes you to risk, that might be a bad thing too. And these were two kind of revolutionary ideas at the time. So why is there this kind of variation? Well, there's warranted variation, as I mentioned earlier. Maybe patients have different needs or different preferences for care. And then there's unwarranted, which is the kind he was referring to, which is just that the styles are different. That 100 meters to the north, they do tonsillectomies on 3/4 of the kids, and where he lived, they do it on 1/4 of the kids. That physicians have this role in not only in the US, but everywhere, of really largely being able to guide the care that patients get and telling patients what to do next, and patients tend to follow the advice. So if I say to someone, you need this, they tend to do it. And so my own different style of practice that might vary from yours may determine, in a broader sense, how much overall utilization the population gets. And there could be some unequal access to healthcare, which we call unwarranted because it should be equal access to healthcare, right? So that's something that could be rectified. These last three things could be rectified. And it looks like about 40% of the variation is warranted and about 60%, the majority, is not warranted. It's just due to these other factors. And so I'm just going to show you the Dartmouth Atlas project that Bruno mentioned, and it's available to you at dartmouthatlas.org if you want. You can look at these pretty maps. And here in the US, we have Medicare as the payer for our older population, people who are 65 and older. And these are per capita Medicare expenditures in 2012 across the US. And these are similar to the geographic hospital-based geographic identities that Jack identified in Vermont. These are just bigger ones there are 306 of them across the entire US. And here, for instance, in Alaska, the per capita age, sex-adjusted, and price-controlled costs of care in 2012 was $6,700, and in Miami it was twice that, $13,000. Big difference, right? We all pay the same taxes for this in the US. It's the same amount that comes out of our paycheck. So it's really a big difference. And so this kind of, and you can see some patterns. You see this kind of regional pattern in the middle where it's a little darker, which is a higher cost region. So maybe there's some geographic variation in kind of the styles that people use in providing healthcare. Up in the Northwest and the Northeast, there's a bit of lower utilization and costs. And so you can see this is a turnip plot that shows Miami at the top and Anchorage at the bottom, and it's a twofold variation there. And this is, again, price, age, and sex and race adjusted. And you can look at different things on the atlas. You can look at back surgery rates, for instance, and this is one of the things we're looking at in France. And when we look here, we see that the lowest rate is in Honolulu and the highest rate is in Casper. And there's very low rates in the Northeast, but relatively high rates across this swath of the U.S., maybe primarily in the Northwest. So you can see that even though before the Northwest had lower overall costs, they kind of have higher rates of back surgery, which is a kind of an expensive and problematic thing because it doesn't work a lot of the time. It just doesn't. It's not very effective intervention quite a bit of the time. And what we see is that Casper and Honolulu, here their rates, and there's about a six-fold rate difference in the rates per capita rates of utilization of back surgery. But Anchorage and Miami, remember the ones who were from before, they're not only are they more in the middle, but they're actually even flipped. Anchorage has more and Miami has less. So you can't just look at overall utilization. You need to kind of hone down and say where is the utilization happening, because it's not like Miami uses more of everything. In total, their costs are way up, but they use less of some things and more of others. So it's kind of an interesting question, and you begin to think, well, what's the right thing to do? Because there's such huge variation, what is right? And that raises this question, well, maybe if you just do more, it'll be better for everyone, right? That has been, until Jack brought that up, that had been kind of the belief. And frankly, it continues to be the belief in the US. We just do more stuff and it's good for patients, right? So it's all justified. And frankly, the problem isn't that Miami is high, it is that Alaska is low. And Alaska needs to catch up and do more stuff to catch up to Miami. So Jack has defined, to kind of look at this question, is more better, Jack defined 3 different categories of healthcare services. There's effective care. This is stuff that you should get. So if you have a heart attack, you should get a beta blocker after the heart attack. It works, it's inexpensive, it's low risk, and it makes you live longer and prevents secondary heart attacks. It's good. In the US, about 60% of the patients who have heart attacks get this. So we're not doing so good on this. This has been known for 25 years. We're not doing so good on providing effective care. There's preference-sensitive care, where, and knee replacement is a good example, where people, as they age, they get arthritis, right? And they get it in their knee. They run too much or run not enough or something like that. And they have a couple of choices. They might get a knee replacement, which is a surgical intervention, or they might continue to get care, like medical care, and get pain medications and do therapy and try to exercise and things like that, and that would, they have a choice. And so they could individually, being homo economicus, right, they could individually decide, given their own risks and benefits of these choices, which they prefer. And so you might think that if people want it, we should give it to them. If we have the money and people want it, why not, right? Give them what they want. And then there's so-called supply-sensitive care, where beds and hospitalizations are a good example. And if you have more beds, they will fill them. You find that there's a twofold variation in the bed supply in New Haven, Connecticut, and in Boston, and there's twofold difference in the rate of admission, because where they're, if you build it, they will come. If you have more physicians, they will use them. If you have more beds, they will fill them. So one of the key questions then is, when we see these differences, these big differences, which of these categories of care does the more money buy? One would hope it would be effective care. You spend more, you would get better care. You would maybe get care that people want more, but you would get less of the supply-sensitive care, ideally, right? So Elliot Fisher, who now leads the Dartmouth Institute, where I work, did a study looking at this, and this graphic just shows the ratio of the high to lowest spending regions. When I showed you those regions on the map, there were 5 different categories. You take the average of the highest quintile of costs or utilization and the average of the lowest, and you simply create a ratio to see what does the highest provide compared to the lowest. And if we look at effective care, the stuff we would want to find, we find that actually when you have the highest compared to the lowest actually provides a little less of the effective care than when the highest provides less effective care than the lowest. The ratio is below 1. So for your extra cost, you're getting less of the effective care that we actually want. For preference-sensitive care, the kind of stuff to where people just might want it, you get about the same and maybe a little bit less. So let's look at the supply-sensitive care, and this is where all the costs are. You get a lot more office visits, you get more inpatient admissions. When you're in the inpatient unit, you get more expensive inpatient admissions into ICUs or CCUs. You get more tests done. So when there's a greater supply of beds, when there's a greater supply of physicians, you get more stuff done, but you don't get necessarily stuff that's effective done. So even that might not matter, right? Because if this is associated, this down here, if you do more stuff and you have better outcomes, then maybe that would be worth it, right? That would make sense. You spend more and you get more visits and people are healthier at the end, then maybe that's worth spending that money. So he looked at this next, is what the relative rate of death across these spending quintiles. And he looked at hip fracture in the lowest spending quintile, quintile 1. He's looking at the relative risk, so it's always going to be 1 for the lowest spending quintile. And when you look at hip fracture mortality in the 30 days after admission, you find that the highest quintile, the highest costs, have a higher mortality rate. And if you do the same thing for colorectal cancer admissions, you find a similar thing. There's higher mortality with higher costs. And the same story for heart attack. So what we're buying then, when we spend more money in the US, appears to be less of stuff that we know works. More stuff that's just stuff, seeing visits and getting tests and stuff like that, and you're getting a little bit of extra death thrown in for nothing, right? So it doesn't make a lot of sense that this is a good thing to have this variation, right? And so 40 years in the US has really found as well, it's kind of expanded on that. There's ongoing and substantial variation in this service use that I covered. We found that more care is not associated with other studies that have looked at patient satisfaction. Patients are less satisfied when there's more costs. There's less care coordination when there's more utilization and costs. There's lower quality care when there's more utilization and costs, and the outcomes are worse. And the problem has been that there's been persistence here. Jack Winberg has been publishing this, Dartmouth Atlas has had data up for about close to 20 years now. And if you look at the last 10 years, the highest spending regions, 75% of them over a 10-year period stayed in the highest spending regions, and the lowest spending stayed in the lowest spending. So unfortunately, just showing this stuff hasn't had all that much of a policy impact in the US. Probably because the way we're funded, where we're very incentivized to do piecework and just to do more stuff. Every time, if I'm a physician, the more I do, the more money I make. And that's how it works. There's less so in France. So it made sense to kind of study this in France, where there's less of this economic incentive just to produce more stuff. So that's what we did, and we looked at geographic variation in France. And this is, we looked at 40 years in the US. France always has a much richer and longer history. And here's the history starting with Emile Durkheim, kind of the father of sociology, one of the fathers of sociology from 1897. So 120 years ago almost, who looked at suicide, published this, and did geographic variation in his publication here. And here, instead of 5 different quintiles, there are 6, and we find that this is looking at suicide rates for about 130 years ago or so. Found 16-fold variation in the rates, with this high group up there in the north and down here, and then differing levels in the middle. And he looked at alcohol, admissions. This is percentage of admissions for alcoholism, right? And Normandy is known, right, I guess, for this. Is that true? A little bit? A little bit. And so we see this pattern from 150 years ago, right? 150 years ago, here's a pattern. And this is consumption of alcohol about the same time, similar kind of pattern where you see that, but you see geographic variation in how people use healthcare services, what diseases they have, and even how they behave, kind of. But since then, interestingly, so in the intervening 130 years or so, there just hasn't been much done in geographic variation in France. There have been a few papers that have looked at some regional, very small sub-regions. One of your 20 so regions in France, they looked at some of those and found some geographic variation, and even some cities, they've looked at that, but there haven't been a lot of national studies. So working with Bruno, we've looked at 2 kind of broad topics. First is variation in admissions for these elective surgical procedures that are preference-sensitive conditions, things like knee surgery, hip replacement surgery, colectomy, things like that. And even things that are like C-section, where there's a lot of potential variation in use that might be attributable to the way that physicians practice and less attributable to patient needs. These are kind of scheduled procedures. They're not emergency procedures. So when we look at heart, CABG, heart bypass surgery, these are scheduled, they're not emergency, so we just look at the scheduled ones. And there's this possibility of overuse and waste and supplier-induced demand in this. The second area we looked at is geographic variation in the ambulatory care-sensitive conditions. These are conditions where the thought is if you had better primary care and better access to primary care, the admission might have been avoided. If you're chronic, a lot of these are chronic disease, they're vaccine related, there's some kind of a minor acute disease that accelerates probably because they don't have access to care as much as other places, and so that uses the hospital bed, and hospital beds are more expensive than primary care. So these are considered wasteful and avoidable admissions. We use data sources from 2008 to 2013, admissions to all French medical and surgical hospitals, and it provided some patient characteristics that we could control for and hospital characteristics we could control for. We used some department level data that had information on resource supply, such as the beds and the physicians and mortality rates and the census, so that we could do age and sex adjusted rates, because it's critical. The demographic distribution is different in the departments. We have to account for that when we calculate these rates, these per capita rates, and compare them. So what we did is do that. We looked at age, sex adjusted department level rates for 96 departments in mainland France and Corsica, and used these rates to calculate common measures of geographic variation. And then we also used some spatial regression techniques to look at the proximity, because sometimes there are kind of broader cultural issues maybe and regional issues that you saw in the US maps that might kind of influence the results that we get. So we looked at those. So first I'm going to talk about the results that we found in these elective surgical procedures. And again, these are multiple treatment outcomes, multiple treatment options that have similar outcomes. So if you have a large prostate, like pretty much every man over 50 begins to get their prostate enlarges, they have problems urinating, and so they can sometimes get interventions, surgical interventions, or they can take medications to manage that. If you have joint pain, you can take medications to manage that, or you can get joint replacement surgeries. If you have heart pain, you can get percutaneous intervention or a bypass grafting, or you can use medication. So these are things where you have two options. The outcomes really are not that different at 4 or 5 years, and the costs are kind of substantially different, but patients might reasonably want them differently. And ideally, patient preferences should determine this care choice. But there are, as I already mentioned, some other factors that might determine that choice, which include the supply of providers and who the patient sees first. If they see a surgeon first, they're more likely to get surgery. So here, I'm just showing you part of our results. These are some elective surgical procedures for patients in France in 65 and older. What I'm showing you here is a box plot. The top is the 75th. This is all of the data from all of the departments, the age, sex adjusted rates for each of the departments. I'm showing you the 75th percentile at the top of the box and the 25th percentile at the bottom of the box. The median is the 50th percentile, the crosshash there, and the high and low rates are there. And I'm just showing you to compare to the US rates. This is the US rate in the black for the same age, sex adjusted group. So 65 and older, our Medicare population. France is just 65 and older population. And what we find is different. We find that there's increasing rate of surgery, spine surgery in this population in France. We see that there are decreasing rates of carotid endarterectomy, radical prostatectomy, colectomy for cancer, and hysterectomy in this age group. We see that for some of these, for CABG, spine surgeries, particularly spine surgery, and the coronary carotid endarterectomy, rates in the US are much, much higher. But actually, the rates for CABG and CEA are converging toward the rates in France. So some of the activities that we're doing in the US to try to contain high costs of care might be working in those areas. And we find that there are a couple of areas where France has much higher rates. In colectomy for cancer, France's rates are higher than the black dots, and in cholecystectomy, gallbladder removal, they're higher. So this may be, again, cultural differences. It might be more foie gras is eaten here, and so that causes you to get more gallstones. I don't know. But there's a variety of potential explanations for this. Similarly, for knee replacement, percutaneous coronary intervention, and hip replacement, we see increases in rates in France. We see a decrease in the rate of hip fractures in France. And we see some areas where the US rates are substantially higher but are dropping a little bit, and some where the French rates are much higher and the US rates are actually dropping a little bit. And this is in TURP, in the prostatectomy, the transurethral prostatectomy. France has a pretty high rate of that compared to the US, and that's a little bit surprising to me, actually, because it's coming out of favor. There's a lot of efforts to make it come out of favor in the U.S. So other findings we found in this study were that there's really not any relationship that we found between these rates and department level income, the density of the specialists who might see them first, the overall admission rate, whether they just overall admit more, or whether there are more surgical beds, or even the proportion of for-profit and not-for-profit hospital beds in each department. We didn't find any relationships there. So that's the the elective admissions for preference-sensitive conditions. Now I'm going to move on to variation in rates of admission for ambulatory care-sensitive conditions. Again, these might have been better managed had there been more access to outpatient care. They're relatively rare, these things are, as individual things, so we group them. This was a British innovation to group them into chronic, which is exacerbations of chronic conditions, acute due to sudden changes in status, vaccine preventable, which are things that you could just have given a vaccine, it would have likely avoided the necessity for the admission later. We also looked at alcohol-related disorders because the belief is that those with better intervention might be avoidable. And there are some others have described, and we combine them into other category. And here we see increases in the overall rates for alcohol-related, vaccine-related, and acute-related admissions in France over the period 2008 to 2013. A decrease in the chronic rate, which is good because you can see the chronic rate is about half of the total of admissions for ambulatory care sensitive conditions. But you still see substantial variation from the high to the low when you look at the dots, right? And alcohol-related is actually getting worse. There's more variation in admissions for alcohol-related admissions here as you move from 2008 to 2013. The high is getting higher and the low is staying about the same. We found that ambulatory care-sensitive conditions consume substantial hospital resources. This is showing the black is for chronic, the chronic ambulatory care-sensitive admissions. The one at the very top is for alcohol-related. You see there's some variation in the number of beds consumed. On the left of each year is the not-for-profit, and on the right is the for-profit. You can see that not-for-profit accounts for the vast majority of consumption of bed resources in this, higher even than their proportion in the nation. It's about 85% of the total consumption. And that chronic care consumes about half of the total bed days of care. But if you were able to avoid these, you could say, this is the equivalent of running a 200-bed hospital at full capacity all year long in each department. That's a lot of resources. And France has run into some healthcare budget issues, and so this might be a place to look for thinking about reducing your budget, if these are truly avoidable. We also found that when you have higher rates are positively associated with higher mortality rates in the general community. They're negative associated with per capita general practitioner supply, which suggests that if you have more physicians in the community, then maybe these actually could be preventable. They might have gone to a general practitioner before. And they are actually seemingly associated with overall use of the hospital as well. And there are some regional patterns that seem to be pretty consistent over time. And here, for instance, are the regional patterns where you see up in the north, there's some more likely admissions for chronic disease. And the northeast is more vaccine preventable. Alcohol-related is up in the northwest. And the total are kind of up in the north as well. So, plus ça change, this is my only French phrase in this, but this is looking at 150 years difference, right? This is the alcohol-related admissions. This is alcohol-related admissions last year in France. It's not too different, which suggests to me that either it's differences in the population, that's just how they are, or it's differences in the culture of how people use hospital care, or some combination thereof. So in summary here, we found a lot of variation in admissions for elective surgeries. There's changing patterns over time. Some are going up, some are going down. There's considerable rate differences when you compare to the US. We found a lot of variation in admissions for ambulatory care-sensitive conditions with increasing overall rates except for chronic. Some regional patterns, and we found that these actually, you're spending a lot of money on these and using a lot of beds for these. There's some limitations here in the research that we had. These are just descriptive associative findings, so we can't kind of claim causation. You might use other different geographic levels, but we use departments because, at least historically, I think that's changing now, but historically that's been how the budget has been distributed. And we don't know whether these admissions were really justified, right? We just know that they happened. We don't know whether they were truly warranted admissions, and that would be kind of the next level of investigation. And we could only kind of impute health status based on things like income and number of comorbidities and things like that. So in the context of these healthcare deficits in France, it seems to us that variation might be reasonably tracked and monitored, that you could help identify in those high outliers places where you might intervene to reduce care costs and care utilization that is likely to be unwarranted. That ambulatory care sensitive conditions, since they're avoidable, might be a policy priority to try to address those earlier than later, and that you could use this kind of geographic analysis and to actually target for the greatest efficiency. So you look at the high outliers, you maybe pair them with the low outliers so they can learn from one another. What's your threshold for admission? How do you do things differently in this region of France compared to this region of France? And maybe there could be cooperative learning that would not be so confounded by like what we have in the US, where the fee-for-service mechanism just encourages everyone to do more. I fear if we did this in the US, that the low utilizers would just take on the characteristics of the high utilizers to make more money, perhaps. And so maybe also you could work with the low utilizers to figure out some use guidelines and even work within across countries, because there's a number of other countries that are beginning to look at this, and that might improve variation and reduce variation, improve efficiency, not only for France, but perhaps for the EU as a whole. Next steps include determining whether patients in high and low use areas actually have different preferences for some of these things, determine whether physicians have different propensities to intervene or to admit, implement some shared decision-making processes where you actively engage patients in the decision-making process, and see if, in the US we found that when you do that, rates drop because patients are actually more informed about what they're getting, and so the rates of utilization and the cost of utilization drop. And provide feedback and see whether just, if you tell people, hey, this is, because right now no one knows this in France except you guys. And so if you told the high utilizers that this is where you are and this is where other people are, in the US that has had some impact. Physicians are kind of competitive lot of people, and they might figure that if they're a far outlier, they could maybe relook at how they practice and constrain that a bit. So that's it. I ran through it kind of quick because of the time, but I think I covered it pretty well. I do want to thank, these are my collaborators in all this work, including some new ones that I've been able to meet here and chat with more recently through this great opportunity that Fulbright and IMéRA and AMU have all offered me. But thanks particularly to Bruno for making this whole thing happen. So thank you.